first up I'll introduce is Professor Masvawure, who is Professor of Practice and Health Studies in the Center for Interdisciplinary Studies at the college. She teaches courses in global health, HIV/AIDS, and health research methods. So we've asked her if she would go first. Tstitsi.
Thank you. Good afternoon, everyone, and thank you for giving me this opportunity. So I'll just share my screen because I'm using a PowerPoint slide deck. Can you see my screen?
Yes.
Okay, great. Let me start the presentation. All right, great. So I teach in the health studies program, as Tom said, and I saw some of the names. I've taught some of you. You've been in my classes. I am a medical anthropologist by training, but also trained in public health as well. So a lot of my courses draw on anthropology, public health, gender studies, etc. So my presentation will focus on just comparing US health to the rest of the world, and also look briefly at how much the US spends versus other countries, and who is insured or uninsured, and the concept of health equity and social justice. And so let's just start off with life expectancy, because I think this is the metric that we all use to sort of determine, you know, if a country is healthy or not. So how long do you live? And so this is from 2019, and the color coding shows you, the purple shows people who live, well, people in countries where life expectancy is 80 years and over, right? So we have Australia down there, New Zealand, etc. We have a large swath of Europe, we have Canada, and the US is in this shade of blue, and the US life expectancy is 79 years. And so usually we'll compare the US to Canada and to countries in Europe. Those are considered America's peers, right? So when we compare the US to its peers, right, we have a slightly lower life expectancy than our peers. And then if we look at the top 20, and this is from 2018, the top 20 countries by life expectancy, right? So these are countries whose life expectancy is high, right? The US is not in the top 20. And when I looked at the stats, the US is, it hovers between 45 and 50. So we're like in the top 50, right? Which again, begs the question, right? This is the US with all the resources that we have. When we use life expectancy as a metric to assess health in the US, we're not doing so great compared to some of the other countries. And the question is why? And I will get to that. And then another metric that is used in public health is this idea of healthy life expectancy. So you could have life expectancy, right, absolute life expectancy of, let's say, 79 years in the US. But in terms of how many of those years are spent in good health, right? So we can see that the US, again, a lot of countries, they fall down, right? So the US is this shade of green, right? So we're like in the 65 to 69, right? So we lose almost a decade of healthy life, right? So when we take the quality of life into account, again, and this is across the world, we spend a lot of time in bad health, which then affects our overall quality of life. And so we're not doing so great, again, compared to our peers who are in this darker shade of green, if we look at Europe, and if we look at Canada and Australia and New Zealand. In terms of burden of disease, again, compared to our peers in the US, our burden of disease is a lot higher, right? So per 100,000 people, right, we have 24,000. And if we compare to other countries, we see that it's much lower, right? So again, the question I want us to be thinking about is, how is this possible in America, which is, right, the most powerful country in the world right now, right? We are the superpower of the world. So how come in terms of health, we're not doing too great? And then just one caveat in terms of our disease burden. So part of it could be we have a higher disease burden, but maybe because we're keeping more people alive when they're ill because of our, right, healthcare. And we'll see when you look at some of the statistics on cancer, the US does much better in terms of curing cancer compared to other countries. But these are just meant to give us, make us pause and ask ourselves what is happening, right? So in terms of healthcare quality and access, again, the US scores lower than other countries in the world, right? So when we're looking at access and quality, so the US is down here in green, right? And this is 88 versus other countries that go much higher. So again, the story that these figures I'm sharing, the story that they're telling is we're not doing as well as I think we should. And the question is why? We spend more on healthcare. And I'm sure a lot of you have heard of this statistic, right? Compared to our peers. So think of some of those countries that are doing well in terms of having a higher life expectancy, etc., higher access and quality, but we're spending a lot more than everyone else. And this just shows that the US spends 54% more on healthcare per person than most developed, in quotes, developed nations in the world. So let's look at the situation in the US. Who is insured and by what type of coverage are they insured, right? So we have, right, a high proportion, almost 92% of people have health insurance in the US and just under 10% without. And then in terms of those with health insurance, right, a big chunk is private health insurance, so almost 2/3, and a large chunk of that private insurance is employer-based insurance. And then we have the public plans, so Medicare and Medicaid. All right, so not bad in terms of insurance. We have a large population that's insured. Who's insured? So now when we look at the 10%, right, the 8.5%, that is uninsured. So let me just go back one slide. So when we look at this 8.5%, in more detail, who are these people? By age, right, not surprisingly, it increases by age. So the age group when we should be working, it almost appears that the years when you're of productive age, we seem to be having, right, large numbers without insurance, right? So 90 to 25-year-olds, 26 to 34, etc. And then the ones that I circled in red, the 34 to 44, 45 to 64, these have the little asterisks, right, which shows that there is a statistically significant difference in terms of this increase between 2017 and 2018, etc. So this increase is not due to chance, it is real, but in terms of the overall trend, right, we can see that we do have higher numbers of people who are uninsured within this productive age group or age range. And then again, still by age, but bringing in other metrics and focusing specifically on children. Because again, as we think about health equity, who should be covered by health insurance, right? And children under the age of 19. So when we break it down, we see that if you're below 100% of the poverty line, right, a higher proportion compared to other income to poverty ratio lines, right? So 7.8 or 7.5, right, going down. And then by race, if you're Hispanic, right, higher numbers were uninsured compared to white, non-Hispanic, compared to blacks, etc. So this breaks it down by race, and this is for children under the age of 19. And then, so I highlighted the ones I thought were really interesting. So when we look at your status, right, are you a citizen or not? So if you're a non-citizen, so you could be an immigrant, maybe awaiting your citizenship status, etc. But this is a huge, right, range. So we have almost 18%, almost 1 in 5, compared to if you're native born citizen, compared to if you're naturalized. And I think behind this category are stories of inequity, right, of fragility. Tom mentioned this word, right, fragile individuals. So maybe our healthcare system is not really protecting the most vulnerable people. And then if we look at by region, right, in the South, And again, this highlights some of the, if we take it back to race, racial inequalities and race histories, particularly in the South compared to other parts of the US, how much of these figures, right, are attributable to some of the racial histories that were experienced in the South, etc. So there's a question I'm raising, hoping, we can talk about this. And then when we look in terms of Medicaid expansion, right, and not surprisingly, if you belong to a state where there was no expansion, right, greater proportion who are uninsured compared to a state that expanded Medicaid. By socioeconomic status, right, again, delving deeper into poverty, right, what's your socioeconomic status, right, when you compare the green to the blue, right, these are expansion states, so they expanded Medicaid, right, in 2018, or by 2018, right? So there are fewer, right, people who are uninsured in the green bars versus in the blue, because the blue represents states where there's no expansion. And when we look by socioeconomic status, right, so it's telling us a story about deprivation and inequality. And then these are the states, if you're interested to see who expanded, who did not, and where do we have coverage. So the ones that are circled are all the states that expanded Medicaid eligibility, either on or before January 1st, 2019, right? So if it's circled, the ones that are not circled, again, some of those southern states where we see higher rates of uninsured individuals compared to other states. And then, so insurance is one metric that we can look at, right? Who has insurance, who does not, right? So just like black and white, you have it, you do not. But then we should also not forget that among people with insurance, there is a substantial chunk that is underinsured. So you have insurance through your employer, but it's not covering as much as you want it to. So 29% of individuals were underinsured in 2018, and this actually went up from 23% in 2014. And then 20% of those individuals who are on employer insurance plans were underinsured. And again, not surprisingly, those who are on individual market plans, right, 42%, right, that's almost half, were underinsured. And then why is uninsurance a problem? It means that you have difficulty paying your bills because you have more out-of-pocket expenses, etc. And a lot of underinsured individuals delay seeking care until it's absolutely necessary. So part of what I wanted to highlight in my presentation today is to have us think about health equity. And I think a health policy should be based on these principles, right? Principles of health equity and social justice. Health equity is about making healthcare available to all on an equal basis. It's about equitable access, equitable use, and equitable quality. And many of the conditions that shape our health are outside of our control, right? So what socioeconomic class you belong to might not be entirely within your control. So how does a health policy take that into account and try and attend to some of these factors that are outside of our control? And health is not entirely a product of individual choice, right? And we do talk about choice, and you can choose your healthcare, et cetera, but to what extent is your health controlled by other factors beyond your individual control? And importantly, health gaps are neither random nor inevitable. So the people who have no insurance or the people who are underinsured, this is not a random act of nature, right? They are individuals, they are policies put in place by individuals that are not working in favor of some individuals. So I want us to think of the policy-making process as, fraught with, it's a political process, and policies, health or otherwise, are not always shaped by scientific fact, but often reflect the interests of powerful groups and institutions. So the fact that you do not have insurance or you're underinsured is not by accident, it's by design. And I think that's something we should take into account as we consider the policies that the different political parties are trying to advance, right? They are individuals behind those decisions, right? And so a good health policy, I would argue, as an anthropologist and also as somebody interested in global health, which is really about justice and equity, right? Our health policies should engage with the social determinants of health. And I feel we don't talk about that as much as we should. So a good health policy should focus more on health rather than on healthcare. And so a lot of my slides were focusing on insurance, et cetera, because that reflects the conversation we have in America. A lot of it is on healthcare, right? Which is really about the practice of medicine, you know, funding and financing, et cetera. And we forget health more broadly. So if you think about the World Health Organization definition of health, right? It's not just the absence of disease, but it's a complete, right, a state of complete mental, social, physical, emotional well-being, psychological well-being. So how do our policies engage with health rather than healthcare per se? And what are the social determinants of health? So think of social determinants of health as the context in which we are born, context in which we grow up, context in which we live, play in, die in, right? So it's essentially your whole life, right? What neighborhood are you born into, right? What is your race? What is the race of your parents? And how does that factor into what opportunities are available for you in zip code X versus another child born in zip code Y with, parents of a particular demographic, right? All of those influence health. So we can't focus narrowly on, making sure people can get, to the dentist, when they have a toothache. We need to be able to say, okay, what is happening in your community that might be predisposing you to particular negative health outcomes. And, we've been talking about COVID-19 since early this year, right? The diabetes, the high blood pressure, right? What is making some communities more vulnerable to high blood pressure, to diabetes, etc., versus other communities? Those are the questions we should be asking, and our health policy should help us zero in onto those issues much more than they're currently doing. So things like race, gender, occupation, so your work environment, what kind of job do you have? If you have a low paying job that doesn't come with health insurance, right, that is a problem. And can the health policy attend to that? And how can it do that? What is your income? So you're working, but you're not earning enough to attend to your other needs. Education, do you have access to schooling, and what kinds of schools do you go to, etc. Social class, and I'm sure you've discussed some of these issues in your various classes and in your various majors, but just taking a moment to think about, should a health policy engage with these issues? And if this is not the place for a health policy, then who should be attending to the social determinants of health, because we know they directly impact individual health and well-being. So to conclude, as voters, I think we should care about equity and justice, and we should support those health policies and programs that seek to reduce inequities and that strive to protect those that our institutions have made vulnerable, right? So I think as a voter, this is the yardstick I think we should use. So rather than are you a Democrat or a Republican or an independent, I think the yardstick should be what policies, if it's health, what health policies is this party putting forward, and do they protect the most vulnerable members of our communities? And if they do not, then maybe that's what should be guiding how we vote rather than party politics, as they say. So thank you very much.
Thank you, Tstitsi. Melissa Boyle.
There's going to be some very complementary themes here and even some similar graphics, but now I will sort of give you the story from an economist's perspective instead of from an anthropologist's perspective. And so actually the way that I want to start here in order to then hopefully frame some conversation during the Q&A is to talk to you generally about justifications that economists give for intervening in markets. And so I want to talk about the markets for healthcare and health insurance and just tell you a little bit about when economists would say that the government is justified in putting its hands in these markets versus letting the free market work to arrive at a particular allocation. So there's two main reasons that economists would say that government intervention in markets is justified. And the first one is when we have a situation where a market does not on its own arrive at efficient outcomes. And this is something that economists specifically refer to as market failure. And market failure is something that economists broadly across the political spectrum agree happens quite frequently in healthcare and health insurance markets. We don't agree on what exactly the solution should be to these various kinds of market failure, but it is not controversial, this idea that healthcare and health insurance markets are wrought with inefficiencies. I'll give you, I could talk about this basically all day, but I will give you two brief examples. The first is that something that we refer to as externalities are very abundant in the markets for healthcare and health insurance. Externalities are, simply speaking, spillovers or third-party effects. So this is a situation in which an economic agent's behavior within a market impacts others in society, and those impacts could either be costs or benefits. So one example of an externality in healthcare is the issue of uninsurance, which we already heard a lot about in Professor Masvawire's presentation. The uninsured impose a lot of costs on others in society. So while we might sort of think that there's controversy about whether one should be obligated to pay for someone else's insurance, I will tell you, even if it's not your personal belief that you should be obligated to help somebody who doesn't have insurance, you should actually have a self-interest in caring about the uninsured, because the uninsured impose large costs on the rest of us. That's a negative externality. That is a justification for government intervention in a market. Another example of a type of market failure that we see in healthcare, and this is particularly also an insurance example, is the problem of adverse selection. When we look in particular at private insurance markets, an issue that we see is that if people are left on their own to decide whether to purchase insurance, the individuals who most want insurance are individuals who most expect to need the insurance. So when we're talking about health insurance, sicker than average people are going to wish to opt into more generous insurance plans. And so those of us who might know that we are going to have high healthcare costs, either because we have particular health conditions or because we have a family history that makes us expect that we are going to be expensive to the health insurance company in the future, are going to be more likely to want to insure ourselves. But insurance only works if you can spread the costs over a large pool of individuals, some of whom don't cost the insurance company much money at all, right? Some of whom are going to make the insurance company a profit, and a small fraction of whom end up being expensive to the insurance company. If you have only sick, expensive people buying insurance, you end up with an adverse selection problem. You end up with insurance companies that can't make profits unless they price their premiums really, really high. And this makes insurance ultimately unaffordable, and it's not going to help sick people who have selected into these plans. It's not going to provide the protection to healthy people should they get sick in the future. So this adverse selection problem can break insurance markets. It can make private insurance unaffordable and unsustainable. And so this is another reason that we potentially might want government involvement in these markets. The other big justification that economists give for government intervention in markets is redistribution. So even if a market is perfectly efficient, if on its own that market is achieving the largest possible economic pie with the resources that are available, we might decide as voters, as citizens, that we do not like how that economic pie is being distributed among the members of society. And we may even decide that we're willing to give up some efficiency. This isn't always necessary, but we may decide we're even willing to trade off some efficiency to have a slightly smaller economic pie in order to have a distribution of resources that we are more comfortable with. So for instance, we may decide as citizens that that people have a right to some basic level of healthcare, right? That healthcare is a human right and that we as a society should provide that. We have decided that in this country, at least to some extent, right? We have laws that say that hospitals, hospital emergency rooms cannot turn people away because of a lack of insurance. We have large public insurance programs like Medicare and Medicaid that provide insurance to particular vulnerable groups in society. So these are ways in which we have decided as voters that we would like for the government to engage in healthcare markets through the form of redistribution. Okay, I also wanted to go through a few fast facts about US healthcare that I think are important to keep in mind when we think about the policies proposed by the two parties and by President Trump and Vice President Biden. Some of these will overlap with the presentation that we saw previously, so I will go through them quickly, which is good because that will leave us more time for questions. So you've already seen that we spend a lot more on healthcare than any other country. So this is a bar graph similar to the one in the previous presentation that compares countries in the OECD. The thing I want to emphasize here, in addition to what Professor Masvawure said in her presentation, while she was talking, I swapped out my picture from a per capita picture, which was what she showed us. I swapped it out for this one, which is actually our spending as a share of GDP. And if I hadn't pointed this out to you, you probably would not have even noticed that my picture is different than the one that she showed us. So what I want to emphasize here is sometimes when people tell you, well, we spend a lot on healthcare, right? The response might be, well, so what? We're the richest country in the world. What better thing to spend our money on than our health, right? And to some extent, this is true, right? It's not bad to invest in our health. But what I really want to emphasize here is not only do we spend a lot more per capita than any other country, we are actually spending a lot more as a share of our wealth, right? Because this is spending as a share of GDP. And you can think of GDP, gross domestic product, as being a measure of national income, right? That's how much income we have as a country. We're also spending a lot more as a share of our income than everybody else. And that is something we should be concerned about, okay? So that's the next slide here. Our spending has been rising unsustainably over time. So our healthcare spending, as we just saw, is 18% of GDP, and it's increasing over time. And although, as I said a minute ago, investing in health is important, the rate at which our spending is going up is something we are very worried about. You have probably heard that healthcare spending is one of the primary concerns when we think about rising deficits over time and what this is going to mean for future generations. It's a huge concern for the sustainability of important programs like Medicare. And one thing that's really worrisome is that a lot of our spending seems to be inefficient. So there's a lot of evidence in the public health literature and the health economics literature that shows that a lot of our spending buys us no improvement in health at all. It's been estimated that about a third of our spending is not actually giving us any improvements in our health. The other thing that we know is that a lot of our spending is buying us the same stuff that people in other countries are getting for much higher prices. So the US has much higher healthcare prices and administrative costs than any other country. You already saw this picture too, but I will just point out, reiterate here that we have worse average outcomes in spite of all this spending than all other wealthy countries. So this again is life expectancy at birth. We would hope for what we are spending that we would be way on the left in this picture. And instead we are over here in between the Czech Republic and Estonia. Averages, of course, do not tell an entire story. But it tells us something about what we're getting or not getting for our money. Another thing that's important to point out is that underneath that average is a very wide distribution of outcomes. So as also was emphasized in the prior presentation, there are a lot of disparities in our healthcare system, much wider disparities than we see in other rich countries. So we have had large and increasing disparities over time, both in healthcare access and in outcomes by race and socioeconomic status in this country. Okay. I also want to emphasize, and this came up when we saw the different types of insurance in the United States, that this system that we have in this country, which we think about as this market-based system that is a private system, it's not really all that private. So we have actually already decided that a lot of government intervention in healthcare is actually justified. About 50% of healthcare in the United States is government financed, and a lot of that spending is through the major social insurance programs, Medicare, which is primarily public insurance for the elderly, individuals age 65 and over, and Medicaid, which is the public insurance program for low-income Americans. And I'll just point out that we all should really care. Again, we should have a social interest in protecting vulnerable populations, but even if you sort of feel like, I don't think it's my responsibility to pay for somebody else's health insurance, I'll tell you that you should have a self-interest in protecting these programs, because hopefully we will all be lucky enough to need Medicare, right? If you're going to turn 65, you're going to need Medicare. If your parents are going to turn 65, they're going to need Medicare. Increasingly, if you are super lucky and you live to be among the oldest old, Americans are relying on Medicaid, because Medicaid actually is the main public insurance program that finances long-term care in the United States. Okay, so these are programs that we should care about, not only because we care about vulnerable populations, but we should care about them out of self-interest as well. Okay, finally, as we saw a lot in the prior presentation, uninsurance has been a very significant problem in the United States. And as I mentioned earlier when I talked about externalities, it's a really expensive problem. So it's a problem that both parties, regardless of sort of general philosophy, should have a strong interest in solving. And a lot of our insurance problem has come from this fractured nature of our health insurance system, the reliance on employer-sponsored insurance, which has kind of come about because of historic accident, and dysfunction in what used to be the non-group insurance market. So part of the Affordable Care Act, about 47 million Americans, or 1/6 of the population, was uninsured. That's a huge number of individuals, okay? It's smaller now, we're at about 8.5% of the population, which is better, but still a problem and still costly. It's worth noting that the US is the only developed country in the world where a significant proportion of the population is allowed to be uninsured. Okay, so to kind of just lead us into the Q&A, I just want to highlight briefly, and I apologize for all the words on these slides, but I just want to highlight briefly some differences between Biden and Trump in terms of their policies on healthcare, so Trump's policies and Biden's proposed policies. And I'm just going to talk about this in two different areas, and then we can talk about more in the Q&A. So I want to highlight there are differences when it comes to the Affordable Care Act and public insurance on this slide, and then I'll talk briefly about COVID on the next slide. Okay, so as you're probably aware, Trump's main goal is to overturn the Affordable Care Act. During his first term as president, he has supported proposals to weaken various provisions of the law. Overturning the law would eliminate the Medicaid expansion. The repeal of the Affordable Care Act would also reverse a number of expansions that have occurred through that law in Medicare coverage, okay? In addition, Trump has indicated support for policies aimed at lower drug prices. We haven't seen a lot of movement on these policies, but he's indicated support for these policies. This is actually a priority of both parties. So this, I think, is actually an area of agreement, which somewhat remarkable today, and has also emphasized cost containment in Medicare. I think there's actually some broad agreement there as well. I think what we could say generally about these policies or proposals is that they would emphasize a movement towards less government involvement, more free market involvement. Almost certainly, however, would lead to a significant increase in the number of uninsured in the United States. Biden, on the flip side, wants more or less the opposite, wants to shore up the Affordable Care Act, would increase premium assistance through the various state marketplaces, so give people larger subsidies for purchasing those insurance plans, because one problem is that for certain individuals in certain markets, the plans have been quite expensive. Biden also supports adding a public option, so a public insurance plan that people could buy into within those marketplaces. That public option would be free for low-income adults who live in states that did not take up the optional Medicaid expansion under the Affordable Care Act. Biden would also reinstate the health insurance mandate, which Trump removed, and would allow Medicare to directly negotiate drug prices with pharmaceutical companies. So again, a concern about drug prices for the elderly in the United States. And finally, would lower the age of Medicare eligibility from 65 to 60. These policies would move in the direction, this is not a Medicare for all, right? This is sort of an intermediate kind of proposal relative to what more liberal Democrats would prefer to see, but would move in the direction of more individuals in public insurance plans, would increase insurance, but this would almost certainly necessitate higher taxes on the wealthy in order to finance this. So the uninsured are expensive, but nonetheless, right, this would not be a wash. This would cost money. Okay, just a few things about their differences on COVID, and then I'll stop and we can move to our Q&A. So I think as most people are aware in terms of COVID-19 policies that we've seen enacted by the president, Trump signed an emergency relief legislation that provided funding to states, provided expansions in unemployment insurance and other sorts of funding for individuals during the COVID emergency. I think a lot of economists would say spending is what we need right now, and we need even more of it. So in order to sort of ward off this recession and help people during this time of both public health and unemployment crisis, spending is what we need. Trump delegated primary responsibility for actual COVID response to individual states. So allowed governors to basically decide what was best for their own states, provided grants to vaccine developers. This is something that universally, I think it's fair to say, economists would say is a great idea. Positive externalities associated with vaccines absolutely should subsidize vaccines. The president has had mixed messages on masks and has frequently clashed with leading government scientists and public health experts, and withdrew from the World Health Organization. Biden, in contrast, has said that his COVID-19 policy would be, he is a stronger proponent of masks than the president. He supports a national mask mandate. This is another externality question. So if I don't wear a mask, I breathe on you, I have COVID. I have just imposed a cost on you if you catch COVID from me. So there is this question of, should we take away your individual freedom and make you wear a mask in order to prevent you from imposing a cost on somebody else? Most economists would say yes, because of that externality problem. Biden says he would expand testing even beyond what the government is doing right now. He has proposed hazard pay and additional PPE for healthcare workers. And he says his messaging would be different. So he says scientists and public health experts would be front and center in communication to the public. And he says that he would rejoin the World Health Organization.
I guess one of the Medicare for all came up at the end, Melissa. And what should I think when I hear that phrase bandied about? It's going to happen. It's a great idea. It's just smoke that is talked about something that's not really going to happen. And I guess for both of panelists, Tstitsi too, would it be something you would want? Would it be a better solution from your perspectives? Something like Medicare for all, whatever it actually means?
Can I start?
Sure.
I think, so again, I mean, this is something clearly the most left-wing Democrats would much prefer to see Medicare for all versus sort of Biden's proposal of shoring up the Affordable Care Act. My personal opinion is that it would be very hard in the current context to move quickly from the system that we have to a Medicare for all type system. It's also not entirely clear what that means, right? So Bernie Sanders' Medicare for all wasn't really Medicare. It was an insurance program that was way, way more generous than Medicare. Medicare is actually not all that generous in terms of the benefits that it provides. So Bernie Sanders was proposing something way more generous than that would have been available to everybody, but also would have been really, really expensive. And so I think moving there, and especially moving there fast, is hard. And I think it's hard for a variety of reasons. I think it's hard because we live in a country where 49% of the population is insured in employer provided plans that on average they're pretty happy with. And so sort of moving people away from that is challenging. We live in a country where we have a very large private insurance industry. And so sort of eliminating that from the economy and moving to single payer healthcare quickly would be hard. And so I think I like single payer healthcare if we could sort of just wave our magic wands and start over. But I think it would be really challenging to move there fast without doing a lot of economic damage and also without making a lot of people unhappy, because we have a wide variety of preferences in the system that we have. So I personally, I'll just sort of reveal my own opinion. I personally like the idea of working within the system that we have already, but adding more public insurance options to that system so that we both insure more people and so that we introduce plans that compete with existing private plans, right? This actually should give us better outcomes from the private insurers as well if they have to compete with a government plan.
Tstitsi, is there anything you want to say on that? Or I have a related question I would ask you, but it depends on what you want to jump in on.
Oh, sure. You can ask me a related question.
So, are there other countries whose policies, whose healthcare systems you look to? Now, obviously, the structures that you're talking about, is there somewhere we could go? And obviously, we talked about Britain before. We talked about Canada in years past. Where do you look for ideas that work?
Oh, wow. I think, and I'll answer this generally because I'm not very familiar with different countries' health policies in detail. But I always think about, our Scandinavian countries, right, who somehow are managing to balance, the requirements of capitalism, but that still has a human face, that still thinks about people, takes care about people, right? So if you think of your Norways, etc., right, they're still capitalist countries, but somehow they've managed to blend the two. And even the UK, right, you have this national health system service, right, where the state decides that, this should be a state responsibility to make sure people have some health insurance, right? And then maybe figure out the money somehow. But I think our starting point, what is our starting point? And I totally agree with Melissa to say the US health system is, as an anthropologist, I'd say it's very unique to the US. This is like US culture, right? So there's a lot that you have to change. It's not the default. It's like a specific, uniquely American thing. And so how do we dig ourselves out of what I see as, a hole that we've created for ourselves, right? Where we've over-empowered, the private sector, where drug companies it looks like they can charge whatever they want, and we don't seem to have policies or regulations to rein that in. So how do we dig ourselves out of this hole that we're in? And the other countries that we can copy from, it has to be done gradually so that we don't create an even bigger problem by, suddenly moving from, this system that we have to something else. I think it has to be carefully managed, but can it be done with the current politics that we have, right? Can it be done in 8 years, even if you had a party a political party in office for 8 years? We're lacking the continuity where we say as a country, we agree this is the way to go, and subsequent governments, whatever their political affiliation, will continue this agenda. So if you only have an 8-year action plan to fix something and then it's reversed by whoever comes in after, I think those are some of the complexities that we have to take into account. And I'm intrigued by Melissa's take as an economist, right? To say, you know, we can start with, should we start with the money, right? That's me speaking as an anthropologist, and say, shouldn't we start with the values to say, health equity is so important to us as a country, and we'll figure out the economic solutions later, right? So which drives which? And in America, the money seems to drive the policies rather than the other way around.
So a question for either of you, I'll take right off of that from the chat box. One of the questions is why our healthcare costs are so high compared to other countries. You mentioned drugs, which are part of it, but I gather that it's your local hospital actually that's the bigger driver. Maybe you or Melissa can answer that.
Yeah, I mean, there's a whole range of reasons, right? A lot of it is we have this very fragmented system. One reason that administrative costs are so high is in fact the fragmented nature of our system. So believe it or not, this surprises people. The federal government is a much more efficient administrator of insurance plans than private insurers. So as a percentage of claims, the administrative costs in Medicare are about 1.4%. As a percentage of claims, the administrative costs in a typical private insurance plan are about 15%. And that's because the government just has a lot more bargaining power vis-a-vis providers and than individuals or individual firms, right? And so we spend a lot more on private insurance because of administrative costs. We do not have the cost controls for things like drugs that other countries have. We also have this wonky system of prices because we have this very fragmented health insurance system where prices don't really mean anything in our healthcare system, right? And different payers pay wildly different amounts. So if you are paying out of pocket at a hospital, you are paying something very different than if you are a private insurance company. A private insurance company is paying something very different than Medicare, and Medicare is paying something different than Medicaid. And so there's...
So it'd be like I could go in and buy a car for 20,000 and you had to pay 60 or something like that, and Tstitsi got hers for 40?
Yep.
Is there anywhere else in our system?
So prices, right? So one of the things that the Affordable Care Act did was it basically tried to increase transparency in prices with this idea that this would cause people to kind of shop around at different hospitals, except that pricing menus don't even mean very much. Shopping around also doesn't mean very much if you're insured and you're not paying that much out of pocket anyway. So insurance actually causes us to consume more healthcare than we would otherwise. That's a problem called moral hazard. So that's actually another market failure problem in healthcare that I didn't mention earlier.
I think Tstitsi mentioned maybe both of you did about the system and the laws being set up by people. They don't just happen, and we have to look at the actual decisions around making them. What can we say empirically about whose interests are well served and whose interests are poorly served, whether by market-based solutions or single-payer plans or the Affordable Care Act? Who are the winners and losers in those decisions?
I will attempt to answer that one. I don't know how empirical it's going to be.
Okay.
But yeah, I think, and so part of my perspective, like when I look at what's happening in the US, is I'm originally from Zimbabwe, Southern Africa. So looking in from the outside as an outsider, right, it feels to me, I think I've been struck, over the years, I've been here for like 10 years in the US, like I've just been struck by how much drug companies can get away with, right? And I don't know if you remember 2 or 3 years ago, the Shrek Kelly guy who raised the price of, one drug, and it was like, I don't know, 300% higher. And it wasn't a crime, right? And he even said that, right? To say, well, I'm not the only one. Every other, big pharma does this, right? And he got away with it. I mean, he was eventually arrested for other kinds of fraud, but that wasn't a crime to say, so it's almost, to me, it's almost like it's capitalism on steroids, where we say, if you can make the money, go for it. And it's not a crime. So how do we come in? So unlike if we look at, and this is the irony, so I'm from Zimbabwe, Southern Africa. We went through IMF, World Bank economic reforms. And the first thing they tell you to do is reduce government spending on the social sector, privatize, and worked terribly for many African countries because healthcare suddenly became expensive, even though you had more options, right? So you had more companies coming in, but no one was regulating even the quality of the different players. And I almost feel like the US is in the same place where, it feels to me like the drug companies are benefiting a lot more than anyone else. And then hospitals, I assume, they're also benefiting because then we pay, a lot of money for our healthcare, and it's not a crime. And then the ordinary person, and it's not even, think of the poorest person, right? Think of even just like average middle class person, where your insurance will only cover 5 things. It can't cover this other thing, right? But you have a condition that requires this other coverage, right? So you start to, play around with health insurance, or even having insurance sometimes doesn't guarantee you good healthcare. You still have to pick and choose and say, okay, I'm not going to do this. And yet there are these other inconsistencies where you have to do your annual test, right? Your annual physical, and these are the things that are covered under your physical. And if you don't, you can't do it less than 12 months before your next, it's all of these regulations that I feel sometimes don't benefit the patient. I have to play around with my insurance. With COVID-19, right, we had people receiving bills for their COVID tests. And I was like, this is a pandemic, this is a crisis. Why am I getting a bill for like $1,000? Where is the central government? Where's the federal government saying, no, you cannot be charged for this because this is a pandemic? So I feel like it doesn't really work for most of us ordinary people compared to the companies and other institutions.
Melissa?
I would say to feel really secure that you are going to get better healthcare in a market-based system than you would get in a system of public insurance, you have to be super rich. So one of the problems in US healthcare is that you can be somebody who is upper middle class, and you get unlucky, right? You have a negative health shock that costs a lot of money, or you acquire a chronic condition that is going to cost money to treat for the rest of your life, and you could find yourself, and even if you have good private insurance, that can become a very serious financial hardship. So I think it's important to understand that one of the things that is broken about our healthcare system is that even if you are somebody who is very well off and has good private insurance, you shouldn't really feel that secure. And that's very, very problematic. So we have way more medical bankruptcy in this country than any other developed country in the world. And so I would say who is best served by a market-based system? I would echo almost no one. Perhaps if you're very, very rich and really can afford any kind of healthcare out of pocket if needed. We have in the United States, we have some of the best hospitals in the world. We have some of the top medical experts in the world, although there are other developed countries that also have excellent hospitals and doctors. And we have a healthcare system where rich people do well. But we have a healthcare system where you're not that secure if you're not wealthy.
So thank you both. It's 5 o'clock already. I can't believe that. But that leaves us with a sense of the stakes and in the election. I want to thank our audience for joining us. The students know from the email that we sent out from the elections forum that there'll be an opportunity for just students to discuss. There's a link there that you can sign up to do that following this. And anyway, I'm grateful to both of you for joining us and for helping us think through the issues. Thanks, everyone.
Thanks.
Thanks.